12 to start webinar series. And this is just the first webinar we are having this year, but other webinars will come along the way into next year. Just as an agenda for today, we'll be focusing on just doing the introduction to NCD investment cases and key components in development process. This one also will be covered by our speaker, who is Dr. Julius Korir. And also we'll be looking at Kenya experience on CVD, that's cardiovascular diseases, investment cases. This one will be done by Dr. Samson Kuhora. And also we'll have country experience, given that this has been a collaborative session. So we'll be having some experiences sharing from the Ghana team, and that one will be done on a tobacco investment case by Mr. Labrams. Uh, Also, we'll have some interaction question and answer session, which will be moderated by Dr. Zida. Next slide, please. At this moment, maybe I can invite Amanda, who is take us through the Financing Accelerator Network, and just give us an overview. Thank you all. Over to you, Amanda.
Thank you so much, Victor, and good afternoon. Welcome to all. It's really a pleasure to be here with you today to welcome you to the FAN and to just kick off today's webinar. I'm Amanda Folsom. I work with Results for Development. We serve as the Global Network Manager for the Financing Accelerator Network for NCDs, FAN. And I'm pleased to be supporting the FAN in close partnership with Access Accelerated, the World Bank, and AFIDEP, who is facilitating today's conversation. For those less familiar with the FAN, just wanted to provide a few highlights of what the FAN is and how it operates. The FAN was launched 1 year ago today, or this month, this past month, so is a relatively new global platform that is growing and has started and launched first in the Sub-Saharan Africa region. It serves as an innovative model to support leaders like yourselves to build resilient health financing systems to strengthen your response to the growing burden of non-communicable diseases and mental health disorders. The FAN is growing into other regions, is about to launch in the Latin America and Caribbean region, and will also be planning for expansion into the Asia and Pacific region in the future. So this is ultimately going to become a globally connected network with regional hubs or accelerators, and AFIDEP serves as that regional host for the Sub-Saharan Africa region. The FAN supports countries through three different mechanisms. The first is through regional expertise, data, and on-demand TA. So improving access to that information and expertise needed to support your NCD responses. Secondly, through catalytic seed funding to support innovative initiatives and programs to strengthen the financing response to NCDs. And finally, through cross-country collaborative learning, using in-person and virtual means of connecting peers with one another to share experience and problem solve and co-create new tools and practical products that can support you as you move forward in addressing your NCD challenges. So that is a bit of an overview of how the FAN works. This session today is really leaning in and is a representative example of that collaborative learning approach. And as Victor shared, will be sort of the foundation for ongoing conversations and peer-to-peer learning around the topic of investment cases in financing response for NCDs. And it's about understanding both the what and the how. And I want to emphasize the how part is really, I think, an important and unique feature of collaborative learning in this peer-to-peer platform. This will provide you an opportunity to share experiences across countries and really unpack what goes into the development of investment cases, how they can be used most effectively, and what is needed. So this session will provide interactive peer-to-peer learning and space for exchange of country experience and access to future technical support as you go forward in this topic, and will help to further refine and focus future learning discussions and exchanges across countries. And it's really designed to be interactive, practical, and really situated in country experience. So I think as a closing thought, as we move forward in this this collaborative learning exchange, we want to just really highlight that everyone here in this virtual room has something to share and something to learn. And I think that's really the driving principle behind this. And so we hope that you'll all participate actively in sharing your experience and insights. And I hope that you'll walk away from today's session and future engagements too with new knowledge and insights and motivation to take action as you return to your desks and continue to work on in strengthening health financing and the response to NCDs. So I really want to thank the AFADEP team for putting this program together, and I'll turn it over to Dr. Zita to facilitate this program. Thank you.
Sorry, I was muted. Thank you so much, Amanda and Victor, and welcome everyone, and thanks again for joining this webinar. My name is Andre Zida, and I'm a senior researcher and policy analyst, and I'll be moderating this webinar. I would like to say that I'm very excited to be here to moderate the experience on investment case development. As mentioned by Amanda, this activity is jointly implemented with our partner Resort for Development, Access Accelerated, and World Bank. So, as also presented by Victor, the project seeks to produce evidence-based investment case development that country can use for budgeting, resource mobilization, and strategic advocacy to accelerate NCDs prevention and control. I would like to introduce our speakers. As mentioned by Victor, we have three speakers. Dr. Julius Corey. Dr. Julius teaches economics to undergraduate and graduate students at the School of Economics at Kenyatta University. He has also conducted various evaluation, research, and assessment related to health sector issues, including development of strategic plan and program-specific strategic plan costing. Dr. Samson Kohoro is a distinguished healthcare executive and policy expert with more than 15 years of government and donors-funded experience, specializing in sustainable financing, policy development, and data-supported decision in universal health coverage implementation. For our last speaker, Mr. Labran Musa. Labran Musa is a leading public health advocate and policy expert based in Ghana, known for his extensive work in NCD across Africa. He also served as executive director of the Vision for Accelerated Sustainable Development, and also has a national coordinator for the Ghana NCD Alliance. He also represents West Africa and serves as secretary within the Africa NCD network. So after presenting our three speakers, I would like to invite the first speaker, Dr. Julius Corey, to start with his first presentation. Over to you, Dr. Julius.
Thanks. Good morning and good afternoon. So I'm going to make the presentation on investment cases. And let's go to the next slide. Okay, so this is the outline of my presentation. It's a very short presentation, and it has those three components. what is meant by investment case, specifically as it relates to non-communicable diseases, the NCDs, the role of the investment case in the national planning and health financing, and lastly, the core elements of the NCD investment case. Now, my presentation is extracted from the guidelines that are provided by World Health Organization. So I've just derived this from that document. So in terms of what is meant by an investment case, or what are meant by NCD investment cases, so these are national economic and political analysis of current and potential interventions to prevent and control NCDs. So most of the investment cases that have been done in the area of NCDs concentrate more on prevention and less on treatment. Of course, there's those who have considered also treatment, but majority of them consider the interventions geared towards prevention and control of NCDs. So the aim of an investment case is to define the cost of inaction, or the current situation, which is status quo, then identify priority areas of action, and after identifying those areas, quantify the benefits that will be derived on these areas of action. So the areas of actions are really the interventions that will be implemented going forward, and the benefits that will be derived from implementing these interventions. So it incorporates, as the investment case, an investment case incorporates both economic and political perspective to ensure that the recommendations are made within the context of institutional capacities and economic and political environment. So for the NCDs, the investment cases are slightly handled in a different way, because it also includes what we call institutional analysis, which is not done in other investment cases. Of course, we have investment case for almost all areas, for malaria, for TB, for RAMCA, reproductive, maternal and child health. But the one for NCDs goes beyond the economic analysis that is done in these other areas to include institutional analysis, which we are calling in this slide political analysis. Is really institutional and context analysis. Let's move to the next slide. So this is a summary of that framework that is used, and the source is WHO guidance on investment case. So we have economic analysis, which really is looking at return on investment to justify the need for resources to invest in NCD interventions. Although the main component is return on investment, the economic analysis will require inputs in terms of the burden of NCD, the costing that is required for the interventions that are chosen, and then the health and economic impacts of the interventions that are selected. Then the second component is what is called institutional and context analysis. Next. So we have those two components of an investment case, the economic analysis and political economic analysis. And economic analysis is mainly a quantitative analysis, while the political component, which is institution and context analysis, is qualitative. And from the economic analysis, the main objective is to generate what we call the return on investment, which is really a summary of the benefits that will be derived from implementing those NCD interventions. So usually when developing this investment case, we consider different scenarios. We can have baseline scenario. It can be called business as usual scenarios, and then consider other scenarios that relates to the scaling up of the selected or prioritized interventions. Let's go to the next. Now, so the interventions which are included are usually derived from the National Strategic Plan, or it can be obtained from the list of a very big list of cost-effective actions or interventions that have been defined by WHO. Of course, within this 88, we have the 16 called the best buys for NCD. So we have a narrow list which countries can select from. So within what we are calling the institutional and context analysis, this analysis, which is qualitative, helps to understand the diverse range of institutions, actors, and stakeholders that influence NCD-related policy in the country. And it provides recommendations that ensure the numbers which are generated through economic analysis, the narratives and policy options emerging from the economic modeling are understood and can be acted upon, because those will be the recommendations that are made. Let's move to the next slide. So the two components, the economic and ICA, then make up what we call the investment case, which cuts, of course, in terms of analysis, it cuts across a different sector. So it's a multi-sectoral response. And therefore, as you complete this investment case, one is in a position to identify the roles and responsibilities of the different institutions beyond the health sector. Next. So in terms of the role of investment case in planning and health financing, one is that it supports government to identify and understand scale up and priorities for increased investment in NCD for prevention and control. So through the process of investment, development of investment case, usually prioritization is done for the interventions based, of course, on impact, among others. And in that case, then the process generates interventions that the country can implement. So those interventions can then go into the planning process. The interventions also can go into the actual implementation. Apart from this, investment case is very important in guiding resource allocation in a country because it identifies priority interventions that can be implemented. Of course, other interventions will be there. So by generating priority interventions, resources can then be concentrated on those priority interventions. But additionally, by identifying the interventions that can be funded, the investment case can then be used for resource mobilization. And especially when the analysis is extended to include available resources and the funding that is coming from different sources. Next. So these are the steps that are usually used or are involved in the development of an investment case. The first one is economic burden analysis, which is just an assessment of the cost of NCDs to the country, and this cost will involve the direct costs and indirect costs, and a lot of the indirect costs will be on productivity impacts of NCDs. So that is the first part. And of course, we have inputs that are required in estimating the cost of NCDs, both direct and indirect. And the approach that is recommended is the use of cost of illness approach. There are three approaches that are there to generate the cost of NCDs. But the one that is more practical is the cost of illness. We have the cost on productivity and another one called a theoretical one called statistical value of life. So these are the inputs which are required to conduct this economic burden of analysis. You estimate the burden of disease, and then there are issues of the effect of NCDs on productivity of labor. So we want to estimate workforce disease burden, and then looking at productivity and productive hours as a result of the disease. And we value these unproductive hours, and we calculate the indirect cost. Next. The second component is really costing the interventions. So once priority interventions are identified, then they are costed, because an investment case will cover a period of several years, usually 5 years. It can move up to 10 years. So in the process, the cost of these interventions and related activities is done. And we have some of the things that are related to this costing, including AP and economic data being collected. And the costing that is recommended is by use of what is called the 1L tool, which was developed by a consortium, including WHO, among others. So this tool is available for costing this intervention. And the tool also has the impact module that is used to generate the impacts of the interventions which are selected. Next. So once the costing is done, the next step is to generate health and economic benefits of implementing this set of interventions. And as I've said, this is generated using the 1L tool. And I've indicated here the modules which are available in 1L tool. It has the module for tobacco, alcohol, sodium, trans fat, physical inactivity, cardiovascular disease, diabetes, asthma, chronic lung diseases, and cancers, breast cancer, cervical cancer, colorectal cancer, among others. Let's go. Then for health and economic benefits, we move from, after generating the health benefits, the next step is really to generate economic benefits through productivity gains. attributed to implementing the interventions. Then the last one is return on investment, which aggregates all the benefits that are generated, and this is divided by the total cost of implementation to obtain what is called return on investment, which is what you get for every dollar or every shilling, whatever the unit of that currency. So for 1 unit of that currency, what do you get in terms of economic returns? Again, in terms of monetary, in terms of money. Next. So this is a summary of the institutional and context analysis. So there are several components that are considered. In terms of step, you define the scope of the problem and assess the opportunities and challenges for response. And of course, we have details on even the kind of components or questions that you can ask within this. The second step is to determine institutional and governance arrangements and capacities. Third is to assess available and potential resources. And this is done qualitatively. The fourth is to identify political economy drivers in the country. Fifth is to propose priority actions and identify key supporters and key opposition, of course, based on the data collected from these other steps. And six is to evaluate potential for change and identify enabling factors and strategies. Next. So that is a summary on the process that we go through to develop an investment case based on the recommendation from WHO. Thank you.
Thank you so much, Dr. Julius, for sharing the step-by-step process for developing the NCD investment case. I've noticed the key information regarding the NCD intervention selection, also intervention prioritization, then costing. You've also shared a very important tool, which is the One Health tool, which has several components and modules, including the impact module analysis that use various serious scenarios building to be able to develop the impact modeling. You also shared experience model on direct and indirect costs that could be included in the process with all the type of NCDs intervention that the tool can also incorporate. Thanks, Julius, for sharing the steps. I also want to invite all the participants to submit all their question and comment in the chat panel. Please make sure to select everyone in the field when submitting a question to ensure that all participants are able to see. And finally, please make sure that you send all your questions before the end of the two presentation, so that the panelists will have the chance to answer some of them. Thanks again. So now I would like to invite our second panelist, Dr. Samson Kohara, to share the country experience, Kenyan country experience on cardiovascular disease investment case development. Dr. Samson, over to you. Thank you.
Thank you, Dr. Zida. I hope I'm audible.
Yes, we can hear you. Thank you.
Thank you. Thank you, colleagues and fellow panelists. I will give you a case in which we developed, specifically targeting cardiovascular diseases. I'll give the background, how we approached it, and the impact that it has had thus far. So basically, this is meant to augment what Dr. Julius has just presented in terms of understanding investment cases. looking at the key components and how we approach them, and then looking at prioritizing cost-effective interventions. Next. So I will first of all take you through the journey in the Kenyan context, because the social insurance platform has been there for 60 years now. And it basically started as a sessional paper that initially targeted only government employees at the point of inception. Then in 1972, it was expanded to cover the whole population. Therefore, both the formal, non-government, and the informal sector could be able to join, but then the scope of cover was largely limited to inpatient admissions. Then in 2012, there was an initiative to expand the cover for the government employees, basically the civil servants, and that's what was called the enhanced medical schemes. And that's the first time when NCDs, as NCDs were covered, but it had a restricted coverage. In 2015-16, there was an initiative to expand the scope of cover and specifically enhance the cover for cancers, for management of end-stage renal failure, and also increase the allocation that was related to chronic conditions, especially surgical interventions and also imaging and radiology interventions. So that's the first point at which we started getting adequate data as relates to non-communicable diseases. The other initiative in 2015 was basically to enhance the cover in the informal sector in recognition that there was a significant proportion of the population that could not afford the premiums. And therefore, the HISP, which is the Health Insurance Subsidy Program, was introduced, targeting the elderly population, targeting the orphans and vulnerable children, and also targeting the severely disabled populations, and their premiums were paid for by government. Then in 2022, we standardized the costing, and we also standardized the nomenclature so that we could be able to make a better use of the data. And this is also the time when we did the return on investment modeling for cardiovascular diseases, and I'll give you the reason why. And then in the recent past, since 2023, there has been a significant shift in terms of how social insurance is administered in the country, and a number of recommendations in that report ended up being implemented in 2024. Next slide. So this is basically the utilization data when we look at the cost by disease category in 2023-2024. If you look at renal failure, it was the second most expensive disease. When it comes to the out-of-pocket payment for this, it was less than 10%. But then the main reason or the main diagnosis for management of the renal failure was 54% of the cases were actually complicated cases of diabetes, and therefore investment in early interventions was actually key. At the fifth most expensive disease, we had hypertensive diseases, where we spent about 3% of the total cost related to benefits or settlement of the claims. And even with that, the estimated out-of-pocket payment, especially related to procedures managing hypertensive diseases, was more than 60%. And then when we look at both inpatient and outpatient, the estimated out-of-pocket payment was about 51%. Then cancers with malignant neoplasms of male genital organs, largely prostate cancer, was the 10th most expensive disease. Diabetes at position 11, and then breast cancers at position 12. Then malignant neoplasms of digestive organs at 17, and that is the estimated cost that we had. That is in Kenyan shillings, about 710 million Kenyan shillings. So with this, there were several questions. One, we were facing the dilemma of how far do we go in terms of financing NCDs, because they are a significant cost driver, and from the estimated data estimates that are available in the country, cardiovascular diseases would be the biggest killer by 2030. And therefore, there was an intervention that was needed. When we looked at the estimated out-of-pocket payment for hypertensive diseases was about, for outpatient and inpatient was about 51%. For the procedures related to the surgeries was about 83%. When we look at cancers, on average, 63% was related to out-of-pocket payment. When we looked at diabetes, estimated 48% was out-of-pocket payment. And therefore, we needed to have a policy reform that was looking at financing early diagnosis, that was looking at making sure that any positive cases were linked to care, and then introduce a tax-based financing model to support the out-of-pocket element, because it was quite significant compared to the national average of 23%. And then there was a third question. Now that we were still having a significant proportion of costs related to communicable diseases, we were seeing a significant rise when it comes to non-communicable diseases. Then what would happen if we had a significant impact when it comes to emerging diseases? And this has largely been brought out because of the COVID pandemic. Next slide. Now, the financing model, especially for the contributorship that has been applied in Kenya since the schemes started, was based on the informal sector making voluntary contributions. So when we looked at 36-month data on how many months is this voluntary contributor retained as an active contributor, and which disease categories are being financed, so that you can be able to look at exactly what would be the motivator to have this voluntary contributor actively making contributions into the insurance scheme. Now, when you look at the gray color, it suggests that non-communicable diseases, specifically cancers and renal failure, because those are the ones which had specific benefits, this proportion was rising over time. And by the time we get to the patients who made active contributions continually for 36 months, about 28% of these cases were actively being managed for either cancer or renal failure. And that suggested that one of the greatest motivators towards a voluntary contributor maintaining active contributions was actually NCDs. So we were losing that aspect of social insurance by the fact that that contributorship was being driven by the more expensive disease conditions. Now, from this, one of the key recommendations was that we needed to shift from voluntary contributorship because of the adverse selection that was exposing the payer to mandatory contributorship. And that is what the current legal provisions are. Additionally, we needed to increase the resources being allocated when it comes to healthcare, especially at the primary level. And that is because most of these cases, for example, cancers, most of the cases were actually presenting in stage 3 and 4. And therefore, early intervention was actually necessary based on this data. Next slide. So with this, and because of the data that we had as far as cardiovascular diseases were concerned, and also as far as adverse selection is concerned, also as far as the out-of-pocket element is concerned, this study sought to answer the question of how much more is needed to significantly reduce the out-of-pocket element. So in as much as it was looking broadly at the interventions that Dr. Korir has mentioned earlier in terms of primary healthcare, it specifically targeted how much more in terms of costs would the payer need to meet so that they can be able to comprehensively finance cardiovascular diseases. So we started by looking at the disease burden. So we defined what the disease burden was, and we augmented this by looking at the literature, not just the utilization data that was available at the national insurer at that time. We also looked at the fiscal space in terms of the published data and the utilization data within the fund. And we defined the high cost of doing nothing. And I think that is what my colleague has mentioned earlier. What is the cost of inactivity? So based on the published data and based on estimates that were available in country, that informed the reason why we needed to have a compelling case to convince stakeholders, especially Treasury, in terms of putting in additional resources to specifically support the financing of cardiovascular diseases. Next slide. In terms of how we approached it, basically the investment case was a mix of research and also economic modeling based on data that was available at the national insurer. We appreciated that within the report, we documented that the insurance coverage was at 26%. So there was a chance that it was skewed. But then that is the most complete data that we had as far as cardiovascular diseases was concerned. So the first thing was to define the scope. And in defining cardiovascular diseases, we used 10 disease categories using the ICD-10 coding that had been used within the insurer model that was there. Second is that we looked at the literature review, not just in country, but also in terms of global prevalence. We also linked the literature to the unmet need within the rest of the population, because as I mentioned, there is a challenge in terms of the population that was covered. There's also a challenge in terms of the unmet need within the general population, because we appreciated that in terms of the number of providers offering specialist services in the country was actually low, and therefore there was a chance that there was a significant unmet need within the population. Thirdly is that we sought to define diagnostic-related groupings, and the main thing about this was to look at the innate indicators within the population and to try to categorize this and other non-communicable diseases within those diagnostic-related groupings. And then finally, the economic model was based on return on investment, where the returns were in terms of productivity benefits. That is in terms of the lives that would have been saved. And for the ones who are hospitalized, what is the reduction in the average length of stay in hospitalization related to these interventions? And then for the ones who are not hospitalized, what is the impact in terms of their productivity? With the assumption that by reducing the number of days of admission or by reducing the number of hospitalizations in a year, that would translate into productivity of that particular individual. And the indicator that was used to mark that is the average daily productivity for the country. And since this was a 10-year survey or a 10-year projection, we adjusted these figures depending on how those 10 years were likely to move out. So since it was between 2023 and 2032, that adjustment was made per year. Then we also looked at the employment benefits by in terms of the value that would create in terms of the active work hours. Then in terms of the expenditure, we looked at the additional costs that the financial would have had to meet or the country would have had to meet to be able to comprehensively cover cardiovascular diseases. So that is the approach that was used when it came to developing the investment case. Next slide. Now, the impacts that we were looking at, we categorized them into three. One is value addition when it comes to the clinical outcomes. So we're looking at reducing the incidence and the risk of these cardiovascular events by virtue of having adequate and early intervention. We looked at the survival rate by reducing the mortalities. So the survival rate of the active cases that were already there. And then three was to reduce the repeat hospital visits, be it hospitalizations related to a repeat cardiovascular event. And the main reason for this is that by having a significant cost being met out of pocket, the probability that the client would default on treatment or will end up having missed appointments was high. And clinically, that was likely to translate into more or repeat events the client experienced over that period of time. So that is the value addition, clinical value addition that we were seeking to address. In terms of the economic value, we were looking at reducing the direct costs related to managing cardiovascular diseases or events related to cardiovascular diseases. Then two was by reducing the frequency of hospital visits, for example, we were seeking to reduce the indirect costs within the population. And then finally, or rather the third bit was to look at what value are we creating for the financials. Remember, the main financial that we were looking at in this was the then social insurer NHIF. So we were looking at what value are we adding to this financial by reducing the average cost being spent per person insured. And then finally, we were looking at how do we get a strategic design and procurement of benefits so that we can be able to get more value for every shilling being spent. So that is the economic value that we are seeking to create out of this study. And then when it comes to the stakeholders and the ecosystem, we were looking at, we had data about 5-year data that was available at the national insurer. How do we use this real world evidence to back discussions with the treasury and also the social insurer as far as financing health is concerned? And then how do we use this data for advocacy, later advocacy, so that more resource allocations could be made as far as this is concerned? And the overall impact was basically a sustainable financing model for cardiovascular diseases in the country. Next slide. So what were the findings out of the return on investment model that we used? First of all, this is the category of the 10 diseases that we evaluated as proxies for cardiovascular diseases in the country, with the most common being hypertension. So this is the prevalence. I think in the previous presentation, there was the issue of the first thing that you do is to map the burden of disease or the burden of the condition in the country. So this is the burden of conditions that we had mapped out in the country. And just to look at how significant this is, for a population then of about 48 million, 6.8 million were likely to present with hypertension. And that was before you adjust for the unmet need. So the burden of disease was quite significant. Next slide. Then the next bit was to evaluate the cost, the incremental cost of comprehensively financing the disease versus the additional benefit, the productivity benefit, and also the employment benefit. So when we looked at the 10 different conditions over the 10-year projection data, this is the return on investment per year and the average return on investment per disease over that period of time. So for hypertension as a disease was at 11 times. Hypertensive heart disease was at 86 times, largely because most of the interventions were related to surgical interventions, and therefore the average out-of-pocket payment was significantly high. That's why you can see the cost variable is actually, or the benefit variable is 8 times more compared to hypertension, where most of the interventions were actually outpatient. Then when we look at two disease categories, that is valvular heart disease and also peripheral artery disease, it's actually a negative gain. And that is likely because of the population that we compared. Since we were running the enhanced schemes, and for the enhanced schemes, the covers were comprehensive, and therefore the fund was meeting all the costs related to the management, and compared that to the national scheme, which is where the voluntary payer looked at. The reason why we had negative values there, it's likely because of the stage of the disease comparing these two populations. So in as much as we had negative ROI for those two, Overall, we ended up having a positive for these 10 conditions. Next slide. Disease conditions, and then we run it over a 10-year period. The active investment in year one would be about 2.2 billion shillings more, but the return on investment would be about 5.5 billion. And then run that over 10 years. By the time we were getting to 2032, the additional investment would be about 3.6 billion shillings a year, and the return on investment would be about 19.1 billion shillings per year. So overall, over the 10-year period, the return on investment was 380%. And then this actually justified why the government or the country needed to invest more in terms of financing for cardiovascular diseases. The conclusion was that there is a significant interface between the practice of basically the medicines and the economics. And therefore, we needed to have a joint approach where the Ministry of Health and the Treasury had a way of approaching and prioritizing what to intervene as far as healthcare was concerned. And the impact of this all is that since 2024 October, we've had Treasury putting in resources into an emergency chronic and critical illness fund. And the main aspect here is that there is an investment, direct investment by Treasury to be able to manage the costs when it comes to financing chronic disease. Additionally, there is a primary healthcare fund where there is an investment in early screening, early diagnosis, and linkage to care. It's not yet fully active compared to the ECCF, but those are the key policy recommendations that have changed in the last 1 year, specifically targeting to support the fact that there is a significant return on investment when you increase the allocations for cardiovascular diseases in the country. So basically, when it comes to the key discussion points, because for each of the 10 diseases, we provided discussion points and recommendations. One is the investment in early diagnosis and making sure that any positive cases were actually linked to clinical interventions. And then two, because of the limitations, the study limitations and the level of data that we were getting, it was important that the country is able to generate and maintain patient registries, especially for the chronic conditions. So the current IT platform that is being used is being designed so that you can be able to generate these registries and actually monitor these patients over a period of time. Then three, there was the issue of prioritizing investment to reduce the costs. These are both annual and lifetime costs related to management of these diseases without altering the quality of care that is being done. Then four, there was the aspect around the macro and the meso factors that are related to cardiovascular diseases, but not entirely within the mandate of MOH. And one of the key things that came up for discussion were what are the policies, economic policies and policies related to urbanization so that we reduce the sedentary lifestyle. What interventions need to be put in place as far as the agriculture sector is concerned so that it conforms to the, or rather it helps in managing the nutritional aspect that is related to cardiovascular, or rather cardiovascular diseases. Thirdly is what is the impact of poverty when it comes to these diseases. It's not entirely in the mandate of MOH, but a joint response was needed to be able to address these factors. And then entirely within MOH, there is the aspect around preventive and promotive health and the public information that is out there as far as non-communicable diseases is concerned. And then lastly is about information sharing and the best practices when it comes to innovations related to financing non-communicable diseases. So those are the key discussion points that came out of the report, and a good number of them are actually being implemented. Thank you.
Thank you so much, Dr. Samson, for sharing the cardiovascular disease investment case development in Kenya. This is a in-country experience that was shared and shows the steps and process, which is in line with the first presentation made by Julius. I've also noticed the scope definition as a key component using the ICD-10 classification codes, the review of the literature, which is an important steps in terms of developing the NCD investment case, as the literature review will show past experience and approach methodology, and has many of other countries have developed the investment case. The definition of diagnosis, related group, and the economic modeling for the return on investment is also one of the key components. By also developing a 10 years projection allows you to develop an economic impact modeling using some of the component. And I would like to remind the participant that Julius, in his first presentation, shows the One Health tool, which is one of the which is an important tool, and that has key modules on impact modeling. It's a user-friendly tool that can help users to develop the modeling, the impact modeling, but also support the costing process to inform decision making. So next, I would like to invite our next speaker, Mr. Labram Musa, to share the Ghana experience on tobacco investment case development. Thank you so much, Dr. Labram. Over to you.
Right. Thank you very much. And thank you for having me. So next slide, please. Next slide. Right. So, just as the speaker said, so I'm looking at the investment case, in Ghana, but with specific reference to tobacco investment case that was done about 3 years ago, and then its impact on public health. Next slide. Right. So, a classical definition of, investment case, I wouldn't belabor the point because I know a lot have been said already. To the extent that it's a strategic, but of course, it should always have, an advocacy component, that builds a compelling argument. And of course, you can't have an argument, a compelling argument, if it is not based on facts, and of course, investment cases are normally based on facts for specific investments. So it is not just for anything, but it must be backed or must have a focusing on specific investment. Now, it details the expected results and then also the priority investment needed to achieve them. So it is more like a specific thing that you want to do. How do you achieve them, and then what are the the investment that you require to be able to achieve them. Now, so I would just want to also let you probably have some definition or how the Ghana investment case came about. So the Ghana investment case case highlights the enormous cost of tobacco in Ghana and the set of recommended policy action that would deliver substantial economic and health benefits to the country. The implementation of the effective tobacco control policies from the WHO FCTC, also can play an important role in strengthening sustainable development in Ghana. So, though my focus is on tobacco control, but it had a ripple effect on unhealthy commodity and then also advancing policy. So some key components of Ghana's investment case on tobacco specifically. So it was able to elicit or came out with some key, drivers or key, figures that would help policymakers to rethink on how to, how to come up with policies that would eventually reduce the consumption of these harm products, and then again, support healthcare. So, as you could see, it actually made us to understand that more than 6,700 Ghanaians die from, tobacco-related diseases, and then that which is accounting for about 3% of all deaths in the country, which is very high. And then also the fact that investing now in tobacco control measures would eventually prevent more than 20,000, deaths in Ghana. And then of course, averting over 1.3 billion in economic costs, because once you're able to also give some projection of how much, you are going to avert in terms of, economic costs by a certain period. And then it also enables us to, to cost tobacco costs, in Ghana, that is moving around 668 million every year, which is equivalent to, 0.2% of the annual GDP, and like I said, if policymakers like the Ministry of Finance sees such figures, or even the Ministry of Health sees that such figures that have economic impacts of maybe inactions, then they tend to, to put in more effort to ensure that policies are aligned with, with the reality on the ground. Next slide. Right. So to continue, so this has been mentioned already, but more specifically in terms of the loss, revenue in terms of GDP, it also highlights the fact that 172 million Ghana cedis, healthcare expenditure to treat tobacco-related disease alone. Government is spending more money to take care of people who eventually, fall ill as a result of smoking, and then also 371 million in tobacco attributable, mortality, and then also 126 million in reduced workplace productivity. When government, entirely, begin to understand that you are losing so much revenue due to the consumption of this product, which will eventually lead to, productivity loss in terms of absenteeism. People losing their lives, loved ones are dying due to consumption. They tend to act, right? And then productivity loss from current tobacco use in Ghana represent 19% of tobacco-related economic, losses. So these are, figures that, that were churned out from the investment case on tobacco. Next slide. Right. So some of the benefit of the, of the, investment cases, that we realized. Of course, you cannot use the investment case alone. Sometimes you need to complement that with other studies. So let me say that once Ghana developed an investment case for tobacco to address specific tobacco control related issues and public health, there were other complementary, documents that also, complemented it. But let me say that I mentioned advocacy in investment case because once the investment case has been developed, civil society organization and other relevant, public health professionals use the document to advance policy. So, for instance, some of the key components, as highlighted earlier, were used to advance, advocacy effort that led to the amendment of the Excise Duty Acts in 2023. So taxes on health-harming products were introduced or, increased. So I'm saying introduced because we have an amendment on the existing tobacco control law or the structure, which was changed from purely ad valorem to a mixture. So currently we have both the ad valorem and then also specific tax on tobacco product, which is giving government more revenue than it was before. There was also an increase in excise taxes for alcohol products in the country. which also giving government so much money. And then also, I mean, there was an introduction for the first time of excise taxes on SSB, that's the sugar sweetened beverages, including, carbonated drinks. I mean, were also introduced, which also giving government some level of revenue. Now, I'm mentioning other products, I mean, because obviously, once, I mean, there's a policy or an investment case on tobacco, you can, conveniently use the recommendation or the component to use same to advocate for for other health harming product, because I mean they align and they work together. Next slide. Right. So in terms of the benefits again, so progress in both, I mean, revenue mobilization and health, I mean, projections. So according to data from the Ghana Revenue Authority, once the Excise Duty Amendment Act once we started implementation in 2023, we saw a significant, increases in fiscal revenue or revenue from the excise taxes, that currently the government of Ghana is realizing. So excise revenue from SSB, sugar sweetened beverages, increased from 735 million in 2022 to 1.300 plus million in 2023 alone, representing almost about 80% rise, within one fiscal year. Currently, I can say that it has gone up even beyond this figure. Similarly, you could see that even for tobacco too, there was an increase from 82 million to currently, as of 2024, to about 220, 27.21 million Ghana cedi in 2024, representing an increase in excise tax revenue for government. So, but collectively, you can see a huge, increase, in excise tax revenue from tobacco, alcohol, and then SSD, which is estimated to close about 1.5 billion Ghana cedi, and proving that public health and taxation can be a major contributor to domestic revenue mobilization. Now there's a challenge, but let's move on. Next slide. Now, so of course, there were some challenges. I mean, in terms of all of this, government have, I mean, as you can see, have developed the investment cases. I mean, the investment cases have been translated into action in terms of coming out with policies even on excise taxes. We are still conducting studies to understand the public health impact. But studies from other countries have clearly shown that an increase in excise taxes for unhealthy commodities has, a very, direct link to improving public health and also reducing hospitalization, reducing, out-of-pocket payments, and of course also reducing, increasing the extent to which government invests in healthcare for people who are dying from these complications from the cancers and other non-communicable diseases as a result of smoking. Some of the challenges that we have had is this, the earmarking. How do we earmark these funds to support healthcare, in Ghana? I know many countries are doing well in terms of earmarking these funds. That has become a challenge, but that is where we are currently on our advocacy to ensure that government dedicates, at least 50% of these revenues to support healthcare and not just go into the consolidated fund. So competing national health priorities and undue political influence is one of the bottlenecks that normally we face even in advocating for policies like this nature. That's why we don't have much of investment cases dotted across the globe, and even in Ghana. Currently, Ghana only have one investment case as far as I'm concerned. I know there are efforts to come out with an investment case on air pollution, and then probably we cascade to look at other investment cases. And the lack of dedicated budgetary allocation for non-communicable diseases. Also one, bottleneck, and that is the reason why civil society, exists to ensure that we provide the evidence for government to understand why there's a need for, such, excise taxes, and then further, earmarking them, and then lack or limited up-to-date and segregation of data on financing. So currently, if you're unable to segregate your data, it becomes challenging. We are unable to actually know how much government is spending, especially on non-communicable diseases, talk less of, specific disease condition. So, then it becomes very difficult to even track or to give proper recommendation that, okay, fine, government, you are making so much money from excise taxes. Now, you should dedicate at least an amount of this money to ABCD. You need to justify and give better recommendation why that is supposed to be done. I recently had a conversation with an officer from the Ministry of Finance in Ghana, and one of the concern is the fact that yes, earmarking is good, but we need to justify why earmarking is relevant. For Ghana, we can't just talk about the federal Ministry of Finance to earmark. The rights authority, which is the Ministry of Health, must justify why they need, extra budgetary allocation. That should not come. That should come from the excise taxes that government is generating. With clear objective, and then how those monies will be used. So these are all challenges that we currently don't have. So these are things that we need to build upon. And then limited sustainable domestic revenue mobilization tools for healthcare financing. So clearly you could see that we are limited, financing tools, though they exist, but locally created ones that would enable government, or that would convince government to, support, the core. Next slide. Right. So, but there has been some innovative, financing, mechanism that the government of Ghana have rolled out, which is good, and I think that I just want to share a few one with you. So Ghana have expanded the national health, benefit package to include more non-communicable diseases like dialysis, sickle cell diseases, and then also some childhood cancers have also been, have been added in the national health insurance benefit package, so that at least people can have some respite, especially the poor and the vulnerable who cannot access healthcare. So this is going to reduce the out-of-pocket payment that people would originally would spend when they go to the hospitals. And then also the uncapping of the National Health Insurance Fund. This year, around March, the government have to uncap the National Health Insurance Fund. Let me explain by saying that, somewhere about 3, 4, 5 years ago, government capped, the National Health Insurance. There's a fund that normally goes into National Health Insurance, kitty to support, all health interventions in Ghana, especially for people who are poor and cannot afford. Unfortunately, however, the funding was capped by a certain percentage, so which prevented 100% of the fund going to National Health Insurance. And of course, that brought about so many challenges about claims payments. People go to the hospital, they are unable to access healthcare as needed, or you go to the hospital and the National Health Insurance packages, or the benefit within the National Health Insurance packages that originally are supposed to support, are supposed to be for free, people normally will be turned away to to go and buy it from outside, increasing the out-of-pocket payment and the difficulties that people living with non-communicable diseases face on daily basis. So this government, this year, have to uncap it. So we are having 100% of the fund going into the National Health Insurance, increasing the fiscal space, for claims, and then also, putting more money into people's, pockets, especially the poor and vulnerable. This year also, the government have committed and has established the Ghana Medical Trust Fund, which is called popularly known as the Mahama Cares Fund, to support the treatment and management of chronic non-communicable diseases and to reduce again the out-of-pocket payment. Now, the government have earmarked 20% of as a seed money to support the enrollment, which is also good to support, to reduce, out-of-pocket payment. And then when this fund is mainstream and start operation, it's going to, reduce, the figures in terms of, the increase, number of the increased cost that people will spend to go to the hospital. But of course, also increased government expenditure because currently the figure is showing that there's huge. If you look at the figure, the percentage of people of funds or household income that goes into healthcare from individual household is very high as compared to how much government is spending, on healthcare, especially for NCDs. So when this policy is mainstream and takes off, and we're going to see, a change in that trajectory, which is good. And the implementation of the pre-primary healthcare, we've been advocating that, government should not only look at, creative, but how do you look at also what causes or the NCD risk factors or the health promotion. So government have also initiated the pre-primary healthcare, at the lower levels to expand access to primary healthcare, including preventive services. So we are going to see more of awareness creation, more of fish screening so that people can be diagnosed early for early treatment so that they will not, present cases at the hospital very late. Now, the challenge, as I mentioned earlier, is earmarking, and that's where we are now, because all these interventions that I've mentioned earlier are good ones. We are advocating so that government would earmark, at least 50%, if not all the excise taxes, to go and support these interventions that I have listed here as, which the government is currently committed to implementing. Next slide. Right. So thank you very much for your attention.
Thank you so much to all the participants, and I hope you found this to be very interesting and useful. And I hope everyone has a wonderful day and a wonderful night. So thank you so much. Thank you for joining us on this very interesting webinar. Thank you and bye-bye.